you're dealing with any exposures, there's a possibility for spread of bloodborne pathogens, which includes hepatitis B. You don't want that. Hepatitis C, you don't want that. HIV, you do not want any of these, okay? So we're gonna start now. Good practices, watch your surroundings, watch your sharps, and watch where you're disposing your needles, okay? And in case we're covering all of our bases here, I've been exposed now what? To blood or body fluids, especially on any sort of mucosa, including your mouth and your eyes, all right? You're gonna wash it with soap and water. You're gonna flush it, especially this mucosa, with water. You're gonna irrigate your eyes if you get it in your eyes. Report it to your supervisors, so pick someone, hey, I've had an exposure, what are the steps I should take, and then they're gonna help you with medical treatment. Please don't make us go through this today. We're not doing this, all right? We're being careful. Okay, that's enough. We've all got it, we're good? Great. We're gonna start off with a little recap. We're gonna move through, most everyone was here last time, and if you weren't, don't worry about it, we'll get you up to speed, okay? So last time we talked about just general injuries and lacerations, right? So we're gonna give you another scenario. You're paged to the ER for a 35-year-old male with an injury, right? Oh, exciting, he comes in, he's rolled in, lights and sirens. Do you run for the suture kit? Or are we thinking about some things first, right? Talked about this last time. We also talked about the different types of wounds. It's open or closed, clean or contaminated, acute or chronic, or internal or external. So I'm gonna leave this up to you guys. And I found some more wounds for you. Sorry in advance, all right? We have a shark bite, open pneumothorax, compound fracture of the wrist, and then a lawnmower injury. I feel like I haven't yet to see a shark bite. Any of these here should not be sutured immediately. Any idea? Just like can't just go ahead and grab the kit. What does this guy right here say? Is the grass in it? I think he's missing a toe. No, yeah, I think we need some debris in there. We need some cleaning. There's a lot of steps that need to happen here. Shark bite, it's probably fine. Open pneumothorax. That means that the lung cavity's been punctured. There's a lot more that needs to happen here before you just start suturing, right? So again, these are just kind of things to keep in mind when someone's placed in front of you before you grab your suture kit, before you start patching them up. Same thing, okay. Stab wound. Again, I don't know what people are doing, right? Seatbelt injury, common. Lightning strike, internal wound. Also presenting on the outside. I can't imagine that's like, it's a burn basically. Penguin bite, didn't know they bit. That was surprising, right? So again, these guys roll into your ER. What do? This guy, this is gonna be a lot of burn care, right? We can talk about that another time, a lot of like topical wound care, hydration. Seatbelt injury, that's an internal injury. We don't know what's going inside. It can be, say liver laceration, anything, but that's an internal injury. Stab wound. There's gonna be a lot of organ damage, penguin bite, you can probably stitch them. Any questions from the recap last time? We talked about our wound healing pathway. Not gonna get into that, unless you want me to. No? Okay. And then we talked about the wound healing, which is primary, secondary, tertiary. Basically, pretty superficial. This is from the ground up, and then this is kind of in the middle. It heals from the inside, pulls to the outside, forms new tissue. Pretty simple. We're done with the recap. I told you we're recording. We're going to talk about infections. Okay. Let's think about the lawnmower injury that we saw there. If that patient rolled into our ER and you said, okay, well, I finally get to practice my suturing skills, right? I learned 3 new stitches yesterday. I'm just ready to get this guy all patched up. Who cares about his mistletoe? Well, we saw a lot of grass. We saw a lot of dirt, debris, probably rocks. Who else knows what? Even if you just kind of like spray that out, say, get a garden hose, do whatever you want. you still have to think about infection, especially in a wound like that. So let's talk about infections, specifically surgical site infections, since as you all are going to be working with different patients in the OR, bedside, etc., these are things that you're going to have to keep in mind, all right? Okay, let's return to 4 more fingers. All right. Number 1, why should we care? So normally wounds, like I talked about last time, primary, secondary, tertiary intention, and these are just the 3 different stages of wound healing, right? Or 3 different ways that it can heal. That's a normal pathway, but possible deviations in this sort of healing can cause delays, right? And commonly it's due to infection, or if you have other complicated wounds such as amputations, etc., but we're talking about infection. So what, right? Like, why should I care? You just dab a little alcohol on it, call it a day? Not necessarily, because infections can, like I said, delay healing, but it can also cause other problems such as necrosis, right? Gangrene, sepsis, and death. So I'm not sure how many of you seen the limbs that are blackened, right? Kind of shriveled up. That's what we're talking about with necrosis and gangrene. You have tissue death that can spread. You have sepsis, where it's spreading to the blood, right? And then all of a sudden you have a systemic-wide problem. And then death. That's a real possibility just coming from an infection. I actually had one patient in the ER who had an infection, diabetic, didn't take care of her foot wound, and her leg was gangrenous all the way up to her shin, right? So obviously that I can't imagine what she has to live with. We're not going to cause this to these people. Okay, couple causes of infection. Last time we talked about the 6-hour rule. So let's say our lawnmower patient, right, comes in and is like, yeah, you know, I ran over my foot, I had a couple of beers, I sat on the couch, didn't really feel it, looked down, 10 p.m., I guess I should take care of that. Well, he's been sitting there for 6 hours. At this point in time, we don't know, we can't confirm where it's been, what's grown. I would kind of describe it as what's marinated in his wound, right? That's the only way I can describe it. So if he's been sitting there for more than 6 hours, we can't go ahead and stitch it up immediately, right? We have to get it started on antibiotics. We have to make sure we properly debride it. We have to clean it. And that's just like a general rule of hand, right? Obvious contamination, get all that grass and rocks. And then if you're in the OR, or if you're doing the procedure yourself, improper sterile filtering tools, like we talked about, are surgical gloves, and maintaining a sterile field. Improper patient decontamination, like if you just left all the grass and everything in there, and improper suture technique. I'm going to pause there. Abscess formation, okay? Let's think about it this way. If you have a superficial wound, like a paper cut, you kind of bring the edges close together, not a problem, right? But imagine if you have a deep laceration, let's say in your thigh. A lawnmower guy got cut open on his thigh. If you bring only the top edges together, what's happening in that space, that little pocket there? That's a surface for the bacteria. That's a surface for anything that wants to grow in there. And that's going to form an abscess or a collection of pus. And it's just going to fester, spread. Then you have your whole sepsis issue we're talking about, okay? So this is a technique skill that hopefully we'll be able to show you guys either this time or the next time. On the patient side of things, there are a couple things that can make someone more susceptible to infection, such as an immune system disorder if they have like lack of complement systems. I'm sure some of you guys remember this. Corticosteroid use, which is an immune suppressant, poor tissue perfusion conditions, such as any sort of heart diseases, diabetes, very, very, very common. Like I said, I saw it lady up to her shin. Chemotherapy, again, another immune suppressant condition, or at least through the medications. So these are on the patient side. And then we have a bacteria, Staph aureus, MRSA, which we talk about a lot. We have the strep hygiene, Pseudomonas, and Enterococci. Okay. So I decided to torture myself. And I decided to find some photos for you guys of these wounds. I'm gonna tell you, I can't do the goo. I can do other wounds, I can do things that are like the goo, I can't do it. So I'm sorry to myself and you guys. It's that. Again, quick thing, surgical site infections, right? Superficial, deep, organ, superficial, skin level, deep, into the muscle, a little bit surrounding tissue. Organ, into the organs, right? And these are the levels of infection, just to kind of break it down visually for you. All right, yeah, I told you. Okay, a couple common ones. Strep pyogenes. This right here, I think the infection began up on his upper thigh, spread, created a compartment syndrome, which is essentially lots of swelling. It starts to damage the tissue, prevent blood flow. They had to cut it open and clean out the infection as it grew. This right here is a pretty early sign of a surgical site infection. You can see the redness. If you get close, you can see some crusting around the sutures. This is the stage that you want to catch it at. If it happens at all, you want to keep an eye out for this. We're not going to let it get to this. And this is what it looks like if it's cultured. Oh man. We have an abdominoplasty lady who had essentially a tummy tuck, and then she had a drain placed, and you can see some pretty significant necrosis, both in her incision site and her drain. And this is aureus grown on mannitol salter garb, which makes it a nice, pretty gold color. Nasty guy. And we have Pseudomonas. So this guy actually came in for a fixation of his tibia. It developed an infection with Pseudomonas, drug resistant. He did end up losing the limb, unfortunately, and if you culture it, it's green. That's what I expect to be green. Even in the wounds, it's green. So if you see that,
It's pretty nasty.
it's very, very.
It's
Yeah,
rough.
I can't do the goo, I told you. And then green, like real life. Oh my god. Okay. So we saw all those. We saw all of the end conditions. We saw a little bit of bacteria. What can we do to catch this in the early stages or prevent it, right? Because this is on you. When you get into the hospital as a physician, as a nurse, you're the eyes for the patient, right? You are advocating for their best interests. So a couple things to keep in mind when you are dealing with these wounds is, number one, visual assessment. Literally use your eyes. If it looks angry, red, inflamed, beyond normal, that's a warning sign. If it looks like the other lady with the giant, like necrosis, that's a big sign. So if you see that there's, like of course, like the pus, if the person is tachycardic, if there's pain, warmth, redness, swelling, very typical signs of infection, that's a tip off to maybe take a little closer look. You can run some labs, which we're all going to be familiar with. You have your white blood cell count, you have your C-reactive proteins for liver enzymes, ESR, the erythrocyte segmentation rate, another inflammatory marker, blood cultures. These are all just like, hey, systemically, are we inflamed? And then you can run some cultures for the bacteria to find out what exactly is growing in that, all right? And it's just, again, just some things to think about, right? There's so much more pathology and microbiology and everything to get into, but this is just to keep in mind when you're approaching suturing for a patient, okay? And again, I love my fun facts. We'll see if you guys find it fun. Infections, we all know, not just bacteria, right? You have your virus infections, your fungi, protozoa, like malaria, you have your worms, hate worms, and then my favorite, of course, you have proteins, right? How many of you guys are familiar with mad cow disease? Let's see. Yeah. You guys know it's a protein?
Prion.
Prions. Yep. And even cooler and somehow scarier, these are misfolded proteins that misfold other proteins. So basically it sets off an unstoppable chain reaction, right? And turns your brain into goo. Like it literally riddles it with holes. There's nothing you can do about it really. It's an infection but caused by proteins. So poor little fellow, but it's an unlucky day for him. So my fun facts, hope you enjoyed them. And now we had a recap. We had a discussion, brief, I tried to keep it brief, on surgical site infections and some things to think about. So what's next? What was that? One more time? That's right, yes. We brought you here all today to actually practice
No,
your
not
skills.
you.
Get out. So excited.
Alicia, would you please get security?
We're gonna practice some hands-on because we can sit here and talk about it all day, right? But until you start to get that muscle memory, then it's just this theoretical abstract thing, right, that you hope to one day learn. So I'm about to turn it over to our dear Jerry Wayne to again talk about field, if I'm right.
Yeah.
Show you guys the knot that we learned last time, and to recap for those that are new. And then we're gonna dive into our kits. All right. Safety, please, 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 do not get me in trouble. I'm not filing for immunity. Okay. Thank you, everyone.
All right, so again, my name is Jerry Wayne. I am very, very excited to see every single one of you. What I want to stress is that if you take nothing away from this time that we're going to spend together learning to suture, the most important things to take away from here is what Hannah Maria was talking about, okay? Learning to suture is a skill, but you have to remember that it is what's called a sterile procedure. Okay? Anything invasive is either a clean procedure or a sterile procedure. When you're putting in needles, when you're putting in IVs, even when you're putting down NG tubes or putting in Foley catheters, they are sterile procedures. They require sterile hands, washed hands, and a sterile area of working. Okay? So it's not just as simple as learning the skill of suturing. You have to make sure that the patient is clean, as Hannah Maria was talking about, that the wound is clean, okay, and that the area is clean, and you are clean. It's called a sterile procedure. And what I'm going to do is I'm going to demonstrate, just like I did last class, I'm going to demonstrate how to open up sterile gloves, and each one of you has some sterile gloves that you can either follow along with me, or you can stop any one of us and ask us later to guide you through it. We'll do it table by table if y'all would rather do it that way. What I'm going to do first is I want to emphasize the importance of a sterile field, and I agonized about what I was going to use. I thought about using a towel. My towel's too big. So this is just a scrub shirt, okay, that goes to these scrub pants. And I'm going to use this to mimic a sterile field, okay? Nursing students, I'm sure that you guys have seen this. I'm really, really glad that the nursing students are here. What is the level of you guys? Is it your first trimester, second trimester?
Third year.
Third year.
And fourth year.
Beautiful.
Third and fourth.
Okay, so you guys, I'm sure, have seen this and done this ad nauseum, right? Okay. How many of you guys are in vet school? Okay, how many of you guys are in medical school? Medical school. Lean in, lean in, lean in. Listen to me. These nurses are not your underlings. These nurses stay with your patients that you admit to the hospital 24 hours a day. They put up with the BS from their families. They put up the BS from these patients when they're complaining about their trays. They clean up after your patients. The heroes of medicine are nurses. Yes, as physicians, we are going to play our part, okay? If you guys get into your careers and anyone in this room mistreats you, call me. I will fly back to Aruba and hand their behinds to them. Why do you guys think that I am so pro-nurse? Anybody want to take a guess?
Because we were nurse.
That's right. I've been an RN before any of you were born, practically. Been an RN since 1998. So I am very, 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 very pro-nurse. All right, so sterile fields, everybody gather around.
I'm since 1989.
Everybody gather around.